just a warm welcome to all the participants and the attendees to the WFNS. This is a joint WFNS ACNS webinar on peripheral nerve. We have great speakers today with some great talks lined up for everyone who's interested in peripheral nerve surgery. I'd like to thank Professor Kato, Raja, and Professor Liu from the ACNS side for coordinating this, and Deborah and Mariano from the WFNS committee who have coordinated and finalized this webinar. So without wasting any further time, I would invite Professor Esham from Egypt to talk about neonatal brachial plexus injury. Esham, unmute yourself. We can see your slides.
Now you can hear me?
Yes, we can hear you.
Thank you. I'd like to thank the organizing committee for this kind invitation. I'll start my talk about management strategies of obstetrical brachial plexus palsy. First of all, I'd like always to start with this painting showing this baby with classic obstetrical palsy, as we can see here in this painting. I want you to look at the eyes of her mother looking sad at the future of her baby with this disease of multiple controversies and uncertain outcome. The obstetrical literature clearly demonstrated that the prevention of neonatal palsy has not been possible by any individual physician or group of physicians. Neonatal palsy knows no geographic boundaries, occurs independent of physician experience, and is found with nearly equal frequency in small hospital and university centers. This table shows the causes of the obstetrical palsy. We have neonatal causes, maternal causes, labor-related causes. Neonatal causes as large birth weight, breech presentation, congenital anomalies. Maternal causes as old mother and gestational diabetes. As we all know, the incidence is between 0.04 and 0.4% of live births. As we all know, the left occipital presentation is which places the right shoulder under the maternal pubis is more frequent. So the right-sided injury is more frequent. In 4% of cases, the lesion may be bilateral. As we all know the anatomy, C5, C6, C7, C8, and T1 rods will form the brachial plexus. C5 and C6 will give us the upper trunk. And C7 alone will give us the middle trunk. C8 and T1 will give us the lower trunk. The divisions is formed by anterior division and posterior division of each trunk. Then we will have the cords, the lateral cord, the posterior cord, and the medial cord. This diagram shows the contribution of each root in the brachial plexus formation. You have to know which root give which nerve, and which areas of the plexus have low number of fascicles and which parts are crowded and have large contribution of all the roots of the brachial plexus as the posterior cord. Pathophysiology. As we all know, when there is shoulder dystocia and the obstetrician pulled on the head, we will have traction injuries like here. And if we have an obstructed head and the obstetrician pulled on the hand, also it can result in brachial plexus injury. This is the types of injury. We have avulsion injury, which is preganglionic injury, which is very devastating injury. We have stretch injury with all hopes of spontaneous recovery. And we have post-ganglionic injury without any hope of spontaneous recovery, but with good outcome after surgery. As we can see here, this is the normal side, and this is the traction side. This is the root, this is the spinal cord. As we can see here, this is the dural sleeve around the root. So sometimes we have partial avulsion of some rootlets with intact other rootlets. We have injury here in the meningeus in the dural sleeve. So we may have pseudomeningeal seal without complete injury. On the other hand, we can have total avulsion, as we can see here. All the rootlets are avulsed from the spinal cord with intact dural sleeve and no meningocele. I'd like you, all of you, to see as these two diagrams or two photos. This is the normal shoulder. This is the head of the humerus, and this is the glenoid. This is has a shape in the normal child. And this is the retroverted glenoid with posterior dislocated and distorted head of the humerus. This is the joint of the baby with a neglected baby with obstetrical palsy. When we look to these two photos, I have one question. Is this a pure nerve injury? Do you think, after you see these two diagrams, that this injury is a pure nerve injury? In my opinion, it's not a pure nerve injury. It's a bony injury, ligamentous injury, muscular injury with developmental affection. So the dealing with obstetrical palsy is completely different from dealing with a traumatic palsy. One of the most unique phenomena that we can see in these babies is co-contraction. Co-contraction between the opposing muscle. It can occur in spontaneous recovery as well as in intraplexus repair due to the simultaneous firing of opposing muscle groups. It can be seen in deltoid with biceps leading to Trombe signs, as we can see here, biceps with triceps leading to lack of adequate elbow flexion, deltoid with shoulder adductor leading to inadequate shoulder abduction. The initial results of co-contraction may be inadequate abduction, inadequate external rotation of the shoulder, internal rotation and contraction. How to avoid this? Close monitoring from infancy, early extensive physiotherapy for the shoulder and other joints, judicious use of botulinum toxin, and monitoring with MRI shoulder. When you have a case of suspected obstetrical palsy, you have many questions to answer. Is it a true diagnosis? What is the type of injury? What are the investigations and when to do them? What is the prognosis of this case? When to start physiotherapy? What is your management plan? And timing of surgery if indicated. First of all, the diagnosis. The diagnosis is easy. The parents, the caregiver can realize that this baby cannot move his right upper limb. It is easy to diagnose. Also, we can have a bilateral injury like we can see in this video. He has bilateral injury. This baby was a child for a primary woman. He was breech presentation and he was delivered through cesarean section. He has bilateral obstetrical palsy. Examination. The examination is very important. You have to have a baseline examination and the serial follow-up examination to have your decision how to manage your patient. You have to examine all the joints, the shoulder joint, the elbow joint, and the hand, wrist and hand. Also, you can recognize ulnar sign and winging of the scapula. There are many scales or many ways to judge the motor power of this baby. First of all, and the most commonly used in all the neurosurgical practice is the MRC and the classification of motor power ranging from M0 to M5. But it is somewhat difficult to use in this baby. So Gilbert and Tassa introduced a modification of the MRC scale to be used in these children, starting from M0 no contraction, M1 muscle contraction, M2 movement with gravity eliminated, and M3 full movement against weight of extremity. Also, Toronto Active Movement Scale is very important, and sometimes I'm always using it. It is classified into two types, with gravity eliminated and against gravity, ranging from 0, no contraction, and to full movement. Against gravity, it will take 7 degrees. Also, there are other scales as modified Gilbert shoulder evaluation scale, Gilbert and Raimondi scale for the hand movement. All these classification can be used to make a standard evaluation and to follow up your patient. But I have a very important clinical note. When you have a child presented to you with upper limb monoparesis with no clear history of birth trauma, you have to exclude central cause clinically and radiologically. As we can see here, this was one of the children which was consulted for me. I was consulted for him as a obstetrical palsy, and there is a central cause. It's a common mistake, and you have to exclude it whenever possible. Classification, we have the classic classification of obstetrical palsy. We have upper root injury, C5, C6, and sometimes C7 is also. It affects the shoulder movement, the elbow flexion, and if C7 is involved, it can affect the extension of the wrist. Lower palsy, avulsion of the lower root, weakness of the triceps, forearm pronators. It's very rare condition, and some authors assume that there is no pure lower trunk or lower roots injury. The total palsy, as we know, the affection of the shoulder, elbow, and wrist, all the parts of the plexus is affected, is also associated with Horner sign and wing of the scapula. Investigations. There are many investigations can be done for this patient. X-ray, we do X-ray to identify the elevated copula of the diaphragm, the associated fractures of clavicle and the humerus. Cervical myelography, it's not, it's a historical issue. In 1947, Murphy et al. Performed a cervical myelography to investigate a possible cervical disc herniation. After they injected the dye, they have harvested this two meningoceles. This patient has traumatic palsy and he had meningocele, and this was the first time to detect meningoceles. Then CT myelography, when I started practicing obstetrical palsy, the CT myelography was the gold standard diagnostic tool we used to detect the pseudomeningoceles. At this time, the MRI was not so advanced, so it was our cornerstone in diagnosis. Now, after the advancement of MRI, the MRI cervical myelography and the MRI brachial plexus neurography now is the gold standard for the diagnosis of this in these babies, as we can see here. Also, the electrophysiological study plays a crucial role in diagnosis and follow-up of this baby. You have to know that you can detect root avulsion when you have absent motor signals with preserved sensory signals. Also, you have to know that sometimes the electrophysiological study is very optimistic. It can give you some more positive results in diagnosis. So you have to depend on your clinical issues. The other very important part of this disease is the natural history. As we know, there is 92% of these cases are transient and they recover spontaneously. When you have partial anti-gravity muscle recovery in the first 2 months of life, you should have full recovery over the first 1 to 2 years of life. Infant with partial recovery of anti-gravity strength at 3 to 6 months will have permanent progressive limitation of motions and stress. Surgery, we have many surgical options and we have many surgical interference, but the important is when to interfere. We have 3 situations. We can have a total palsy with avulsed roots, with signs of avulsion by examination and by radiology. This patient will be scheduled for surgery. There is no rule for conservation, but we will wait until 2 or 3 months to do our surgery. The other situation, when we have a partial injury, we have 2 degrees of partial injury, trivial injury, very limited weakness, early progressive improvement, and this patient will not need surgery. The third situation is patient with modest recovery. At 3 months, we have biceps, we can go for rehabilitation and conservation. At 3 months, we don't have biceps, we have to go for surgery, or we can wait until the 4th or 5th month. Then we will do our surgery. We have many surgical options. We have neurolysis, nerve transfers, and direct repair. But this will depend on which situation we find. When we have C5, 6 injury, it may be a postganglionic injury, rupture injury, and it may be a preganglionic type. When we have a postganglionic type, you can go for anatomical repair, all routes to divisions, and spinal accessory to suprascapular. In case of preganglionic injury, avulsion injury, we have to do spinal accessory to suprascapular, triceps motor fascicle to the axillary, then upper lead for biceps. During our exploration of one of our cases, we had this neuroma and continuity. This is the roots, as we can see here, and this is the distal parts, and all the upper trunk and part of the middle trunk are replaced by neuroma. In this situation, what we can do? Most of the surgeons will go for resection of the neuroma and reanastomosis using sural nerve grafts. Some others can do adhesolysis. Then we will go for tendon transfer, spinal accessory to suprascapular, and Perlin for the biceps, and we may have 𝒐𝒏 operation for the shoulder. But most of the surgeon will go to do resection of the neuroma and anatomical repair by sural nerve graft. As we can see here, this is our neuroma. We can remove as much as we can till we have a healthy proximal end, then to have a healthy distal end, then we'll replace this with grafts. As we can see here in our exploration, this is the root and this is the trunks and this is the sural nerve grafts. Another case, we did anatomical repair from C5, C6 to the upper trunk. Another situation, you can have this situation. This is the lower trunk, this is the middle trunk, and this is rupture of the upper trunk. I think there is no hesitation. We can go for sural nerve grafts here. The gold standard in this situation, C5 to one division, C6 to the other division, and spinal accessory to suprascapular. On the other hand, we can have total avulsion, as we can see here, or avulsed roots. When we have avulsed roots, the situation is different from traumatic cases or adult cases. The hand is, in the adult cases, the hand is not a priority, but in the children, Gilbert and his colleagues emphasize that the hand is a very important and crucial to reconstruct in these babies. When we have a global palsy, after exploration, if you have 4 or 5 roots, it's very easy and you can go for anatomical repair. I think the obstetrical palsy, we are all inside of anatomical repair. Then you can have 3 roots only. As we can see here, if you have 3 roots, 1, 2, 3, or other ones are intact. So one of them will go to the lateral cord, one of them will go to the posterior cord, and the last one will go the medial cord. If this is in case you have 3 roots. And in all this, in this maneuver also, we will give spinal accessory to suprascapular. Another situation, if you have 2 roots, you will give 1 root to the medial cord, to the hand, to go to the hand through the ulnar and the medial nerve. So one of our roots will be given to the medial cord. The other can go to the posterior cord, or you can divide it, if it's a good root or good motor donor, between the posterior and lateral cord. And also, you have to give spinal accessory to suprascapular and 2 or 3 intercostal to the biceps. If you have only 1 available root, you will give this root to the lower trunk to the medial cord. Then you will have spinal accessory to suprascapular and intercostal to biceps. If you have 0 roots, it's a very rare situation and a very rare condition. You will give spinal accessory to suprascapular, 2 or 3 intercostal to biceps. Then you can take the opposite C7 or contralateral C7 for the lower trunk or medial cord. Some authors assume that the contralateral C7 can work in this situation very good, more than the adults. Here we can speak about the Perlin procedure. Perlin procedure is a procedure for a re-innervation of the biceps muscle to restore elbow flexion. This is the muscle, and this is a branch of musculocutaneous, the motor branch to the muscle, and this is the ulnar nerve, as we can see here. We will cut off the motor branch of the biceps, then we will open the ulnar nerve. We will take a motor fascicle of the ulnar nerve to re-innervate the biceps. As we can see here, this is the ulnar. We will take a motor branch to the biceps. The question here, which motor branch of the ulnar we will take? As we can see here, you will take the motor fascicle, which make a wrist flexion to the flexor carpi ulnaris. Avoid to take a branch from the hand or the small muscles of the hand. Another way to re-innervate the biceps in case of total avulsion, it is the intercostal nerve. You can take 2 or 3 intercostal to re-innervate the biceps through the motor branch to the muscle. While the baby are still under anesthesia, they have to be put in a cast. As we can see here, this cast to fix the head to the neck to the arm, as we can see here. We will keep them in this cast for 3 weeks. We have some cases, an 8 months male baby presented to us with total obstetrical palsy. This is the follow-up of our baby after 12 months and after 2 years. Another case presented to us with upper palsy, and this is the follow-up of the baby. Another case also with upper palsy. These are videos of 2 cases of upper palsy, as we can see the recovery of the babies. This baby was presented to me with total palsy. She had a flail limb, and now she is 10 years after surgery. It was very devastating injury, but now she is doing somewhat well. On the other hand, you can have these children at this age, 10 years old or more, with a neglected palsy, as with this limited improvement, and there is no place for microsurgical repair. Here you have to decide to take the other step, is the tendon transfers, muscle transfers, and the secondary procedures. I know there is no time for this today, but we have this baby with limited shoulder abduction and external rotation. As you can see here, we went for tendon transfer, latissimus dorsi transfer for her, and this is a post-operative. Another baby also with limited abduction, external rotation. We have latissimus, teres major, subscapularis release, and this is the post-operative photos for the baby. So it is never so late. Although the incidence of fresh cases are decreasing, but there is large number of old neglected cases that may benefit a lot of secondary procedures. Conclusion, unfortunately, a severe obstetrical palsy is not a solved problem. Early examination should be done to establish a baseline of patient's neurological status. Timing and the indication of surgical interference are still a matter of controversy. Follow-up of our patient shows satisfactory recovery after microsurgical repair, which is superior to natural history of the disease. Thank you.
Thank you. Thank you for the great presentation, Esham.
Thank
Any questions from the panelists? Any comments from the panelists?
May I ask one question, Professor?
Yes.
Yeah, Professor, thanks for a nice presentation. Actually, 2 questions I want to ask. One is, when do you use muscle transfer in your cases? Second question is, how can we, as a neurosurgeon, help to reduce the incident rate of brachial plexus injury? What role can we play in prevention? Thank you, Professor.
Thank you. The first question, some authors assume that you can do microsurgical repair after 2 years, the cutoff 2 years of life. Gilbert and Raimondi assume that we can do surgery up to 4 years, microsurgical repair. In my opinion, you can do it after 2 years, after 2 years of life. As early as you can. Some cases of obstetrical palsy, when I follow them up, they don't need microsurgical repair. So they have some shoulder affection, and they will benefit from muscle transfer. So I do it after 2 years, at 2 years of life. After there is aggressive changes in the shoulder and deformity, bony deformity, and ligamentous deformity. The second question, I don't think we have a rule to prevent the obstetrical palsy. I think the obstetrician can play the crucial role. But I think the rate of new cases are becoming so rare. There is no large number of fresh cases, and they are doing their best to avoid it.
Thank you, Professor.
Thank you.
Esham, may I ask one question? Do you use Botox for especially the shoulder internal rotator spasms? We see a lot of them, usually 1 year, 2 year, 3 years. These patients kind of recover and then they kind of plateau. And then we see that the internal rotators are going into early contractures or signs of contracture. So we give Botox, and then my personal experience is that works very well and restores the extent, the range of motion of the shoulders very much. So what is your experience with Botox?
We use Botox during the early recovery to give a chance for the recovering muscle, the abductors and the external rotators to work more strong. But I think Botox is not a final solution. It gives you temporary improvement, and it can support your decision for muscle transfer, I think. But when your muscles are recovering and you decrease the opponent's muscle, so you can have a better result. So Botox is very important tool, but you should be you should use it when it is highly indicated. It's my opinion.
It's also helpful in co-contractions, especially so that you biceps, triceps co-contractions, you
Yes,
can
yes.
do it in triceps. And then yeah, you are absolutely right. You have to counsel the patient that it is going to be a temporary effect and you have to maximize physiotherapy and all the measures so that you restore the primary muscle which you are targeted with your surgery. I think that's a
Yes,
good point.
yes, I use it. I always use it, but I think also we have to identify to our colleagues that the tendon transfers and muscle release can play a crucial role in the improvement of our babies.
Absolutely, yes. Yes,
Yes.
great, great. Any other questions from fellow panelists? Do we see anything on the chat? Okay, so we can always ask questions on the chat if it's possible for all the attendees who are participating. Thank you, Esham. I think we'll move to our
Yes.
next speaker. This is Dr. 𝒂𝒔𝒔𝒐𝒊𝒂𝒓 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂, my very good friend from Thailand, and he will be discussing about the role of nerve transfers today. Over to you, Jake.
May I share my PowerPoint here?
Yes.
Yes.
Yes, we can see your
Okay.
presentation and
So
your.
good afternoon. Yeah, good afternoon from Thailand, everyone. I am a 𝒂𝒂𝒂𝒂𝒂𝒂𝒂 neurosurgeon at Neurological Institute of Thailand. First of all, I would like to say thank you to the ACNS for having us from the people in the ACNS webinar. My topic today is about adult brachial plexus injury and the role of nerve transfer. I think you all might get used with this diagram. In this segment, the spinal cord keep of the ventral root and the dorsal root. The dorsal root have the group of cell bodies that form the dorsal root ganglia. Then the dorsal root ganglia and the ventral root combine to the spinal nerve. The spinal nerve gives off the ventral ramus and the dorsal ramus. The ventral ramus of C5 to T1 form a complex structure called the brachial plexus. You all hear from the 𝐻𝑒𝑚, from root, trunk, division cord, and the distal nerve, respectively. So in adult, the most common mechanism, about 70% of the brachial plexus injury are caused by stretch injuries, and the rest, about 30%, are caused by penetrating injury that might be caused by stab wounds, blast injury, gunshot injury, or another common mechanism I found that is iatrogenic injury that might combine with stretch, ischemic, and thermal injury. If we focus on the most common mechanism, the stretch injury, it depends on the position in which the patient got injured. If the patient falls with the widening angle of the neck and the shoulder, it's likely to cause the stretching to the upper part of the brachial plexus. On the other hand, if the patient falls with the widening angle of the arm and the trunk, it is likely to cause stretching to the lower part of the brachial plexus. The patient can present with clinical upper brachial plexus injury, which is the involvement of the mainly C5-6 root or upper trunk, causing the weakness in the shoulder abduction and elbow flexion. Or they can present with the lower brachial plexus injury, with the involvement of mainly C8-T1 roots, causing the impairment of the hand function. Or in the more severe form, the patient might have injury of the whole brachial plexus called total brachial plexus injury, causing the failed arm. One critical factor in brachial plexus injury is determining whether the injury is pre or post-ganglionic. The pre-ganglionic lesion is highlighted here in green. The injury is proximal to the dorsal root ganglia. It might be caused by the root avulsion or root transection. Another type is post-ganglionic injury. The injury is distal to the dorsal root ganglia. It might be located in the proximal level in the supraclavicular region, or might be more distal in the infraclavicular regions. Here is the list of findings that are suggestive of preganglionic lesions. So why we have to differentiate between these two locations? Because the prognosis and the management are different. The preganglionic lesions will not recover spontaneously. So surgical intervention is needed, and you can do it as soon as possible. And the surgical options are different between the pre and post-ganglionic lesions. So now we talk about the management of brachial plexus injury in adult. The two main questions is that need to be answered are when to do and what to do. To answer the first question, I summarize here in a diagram. If you have got a patient with open brachial plexus injury, it is quite straightforward if there are associated vascular, tendon, or bone injuries that need urgent or emergent exploration, you can simultaneously explore the brachial plexus. If the nerve got sharp injury, you can do the primary repair, or you can still wait for a few days, maybe 3 to 5 days, and perform the early repair. If the injury was open, but the mechanism is blunt injury, the nerve got contused, or the wound was dirty, it was recommended to wait for 2 to 6 weeks, then perform the early secondary repair. If the injury was a closed injury, no open wound, we recommend to do the clinical assessment, electrodiagnostic testing, and imaging to classify whether the injury is pre or post-ganglionic lesions. If the injury is pre-ganglionic, you can proceed to the earlier nerve repair as soon as possible. But if you suspect a post-ganglionic lesion, we recommend to wait for 8 to 12 weeks period because this type of injury might recover spontaneously. After the follow-up, if there is recovery, there's no surgery needed. But if the follow-up showed no recovery or incomplete recovery, you can do the delayed secondary nerve repair within 6 months of time frame. I want to emphasize here the limitation of nerve repair after the nerve injury, that the time is muscle. The surgical interventions more than 6 months in adult after the injury are rarely result in meaningful recovery. When the brachial plexus injury occurs, the first priority for repair is the elbow flexion, followed by the shoulder abduction. The functioning of the hand, especially in the intrinsic hand muscle, is very difficult to regain. If you read the textbook that was published more than 10 years ago, it would mention that the reinnervation of hand function is still out of reach. But with recent techniques of nerve transfer and tendon transfer, the hand function recovery is possible. The next big question is what to do. How can we repair the injured nerves? A popular option is the nerve graft. You cut the segment of a nerve that was injured and use the harvested nerve graft to connect the gap. This is useful with patients with post-ganglionic injury, not the option for periganglionic or avulsion injury. The nerve stump must be resected to the healthy fascicle before the repair. Otherwise, you will suture the graft to the scar, and the axonal regeneration will not happen. Another downside of nerve graft is the aberrant axonal regenerations. Since you cannot control the direction of axonal regeneration, the motor axon might grow into the skin, or the sensory axon might grow into the muscle, and that might cause ineffective nerve repair. There is also a limitation with the size of the nerve stump and the nerve graft, of course. There are risks of donor morbidities. Usually we take the graft from the sural nerve, causing the numbness of small area of the lateral side of the foot. The surgical option I want to highlight today is the nerve transfer. This is the transection of functioning nerve, functioning donor nerve fascicle, and the proximal stump of that fascicle then connected with the distal stump of the non-functioning recipient nerve. The pros of the nerve transfer is this is the wideable option for root avulsion injury. The repair site is closer to the motor end plate of the recipient muscle, resulting in faster motor recovery than the proximal nerve graft. It decreases the risk of aberrant axonal regeneration. It is not always true, but usually you are likely to take the motor branch of the donor nerve and connect it to the motor branch of the recipient nerve, and that might result in more reliable recovery. The downsides of nerve transfers are the limitation of the donor nerve, especially in the total brachial plexus injury. And also there are risks of donor morbidity too. We talk about the first priority of the nerve repair, the elbow flexion. The nerve transfer for the elbow flexion mainly divided into plexo-plexo and extra-plexo. The plexo-plexo nerve transfer is the transfer that you take the donor from the functioning nerve in the brachial plexus and transfer it to the recipient nerve in the brachial plexus. For example, if you got the patient with upper brachial plexus injury, and with impairment of the elbow flexion, the lower part of brachial plexus is still functioning. So you can take the FCU fascicle from the functioning outer nerve or the FCR fascicle from the functioning median nerve and transfer it to the nerve to biceps. The extra-plexal nerve transfer is the transfer that you take the donor from the nerve outside the brachial plexus and transfer it to the nerve of brachial plexus. For example, you can take the intercostal nerve, the phrenic nerve, the spinal accessory nerve, which is cranial nerve, or contralateral C7, and transfer them to the musculocutaneous nerve. The nerve transfer for shoulder stabilization is the same. You can use intraplexal nerve, a branch of radial nerve, to transfer to the axillary nerve for shoulder reconstruction. Or if the functioning intraplexal donor is not available, you can choose the extraplexal nerve, such as spinal accessory nerve or phrenic nerve, to be the donor. The repair strategy depends on the injury pattern. From here, I will give you an example of strategy we use for brachial plexus reconstruction in the form of case illustration. The first case here is the patient with a motorcycle accident with weakness of shoulder, abduction, and elbow flexion. The functions of triceps, wrist extension, and all hand function were preserved. From the clinical presentation, the MRI and the electrodiagnostic study support the diagnosis of post-ankle injury. The patient did not recover well after 6 months of follow-up. The function that we want to reconstruct are the elbow flexion and the shoulder abduction. In the case of post-ankle injury, you have options to do brachial plexus injury exploration and nerve graft, or to do distal nerve transfer. Actually, you can do both. Here's the area of injury highlighted in red. If you choose to do the nerve graft, of course, you have to cut the neuroma in continuity and perform nerve graft to the suprascapular nerve, lateral cord, or the posterior cord. The nerve graft might benefit in patient with neuroma pain and patient with limited donor, but you have to evaluate the extent of injured nerve. Sometimes it might require long segment of the nerve graft for reconstruction. Another downfall is the limitation of the nerve growth, which can be regenerated at rate of 1 millimeter per day. If you do the proximal nerve graft, it might take longer recovery time to re-innervate the distal muscle. Another option is to perform the distal nerve transfers. In this case, you have multiple options, including both plexal and extraplexal nerve transfer. You can do the FCU fascicle of outer nerve, transfer the nerve to biceps, or call overlap procedure for the elbow flexion. And you might do the spinal accessory nerve transfer to the suprascapular nerve or Lee-Schwang-Wong procedures for the shoulder abduction. The pro is that it shortens the recovery time since the repair site is closer to the target muscle. And it might decrease the aberrant axonal regeneration because generally you take motor branch to transfer to motor branch. In this case, I chose distal nerve transfers for this patient. The first procedure I did is the classic operation called overlap transfer, first proposed by Christoph Overlap in 1994. I opened the bicipital groove, the groove between the bicep and triceps, identify the median nerve, musculocutaneous nerve, and its branch to biceps, and the outer nerve. I opened the epididymium of the outer nerve and identify the FCU fascicle. It would be like presented by Dr. 𝒂𝒔𝒔𝒐𝒏 here. So I use electrical stimulation to identify the FCU fascicle supplying the wrist flexion versus the branch to intrinsic hand muscles. It is critical here to cut the correct fascicle, otherwise the patient will wake up with intrinsic hand weakness. Let's go. Okay. Then you co-app the proximal stump of the FCU fascicle to the distal stump of the nerve to biceps. For the shoulder abduction, I did spinal accessory nerve transfer to the suprascapular nerve. Another operation I did is the transfer for transfer of the tricep branch of radial nerve to the anterior axillary nerve. It's also critical too to select the right fascicle. Here I use the electrical stimulation to confirm the branch of tricep before taking it to the to use as the donor nerve. Here's the branch of tricep. So I take the fascicle of to the medial branch, to the medial edge of tricep and flip it back to co-app with the anterior axillary nerve. Sorry. Okay, gotcha. And this is the outcome at 1 year post-op. The function of the shoulder abduction and the elbow flexion will recover very well. Here, the elbow flexion, okay. Another scenario is the post-ganglionic posterior cord injury. The patient have persistent weakness of the muscle innervated by posterior cord at 4 months after the injury, with the impaired function of deltoid bicep supination, wrist extension, and finger extension. Yes, it's post-ganglionic, and you can choose either to do the nerve graft or to do the nerve transfer. What I did for this patient is I decided to do the exploration and perform the nerve graft in this patient. The injury extends from the supraclavicular and infraclavicular in the MRI, so I did supraclavicular and infraclavicular exploration. And I found a long segment of the posterior cord, the neuroma and continuity. Actually, I cut the neuroma for longer than I showed here, and I did kind of 8 centimeter cable nerve graft for this patient. At 1 year post-op, there is good recovery of the deltoid, tricep, and supination, but there is no recovery of wrist extension and finger extension. You can see here the limitations of the nerve growth of the nerve graft, because the nerve growth just 1 millimeter per day, so it might take longer time to re-innervate the very distal muscle. The most severe form of brachial plexus injury is the preganglionic total brachial plexus injury, which is very challenging injury pattern. You cannot do the nerve graft, so the distal nerve transfer is the only viable option for nerve operation, and it must be only the extraplexal nerve transfer. For example, you can use 2 to 4 branches of the intercostal nerve and transfer them to the proximal musculocutaneous nerve. And the functional recovery is not that good. It's the successful is ranging from 40 to 70% of the case. For lower brachial plexus injury, the reconstruction to recover the hand function is even more challenging. The nerve graft is a proximal site of injury, rarely result in functional recovery of the hand. So in the past, major operations are tendon transfers. Recently, there are increasing reports of using distal nerve transfer to re-innervate the hand functions. For example, I have a case here with C8T1 iatrogenic injury. The root was cut as very proximal, close to the thecal sac, and the nerve gap is about 8 centimeters. I perform early repair with a nerve graft with 10 centimeter interposition sural nerve graft and wait for a year, and there is no recovery. So I decided to perform distal nerve transfer at a year after the injury. I do the brachialis to the AIN transfer for the pinching of the thumb, and the ECRB transfer. The patient can still extend can do the wrist extension. So I take the nerve to the ECRB transfer to the FDS for the finger flexion. So this is not included in my but yes, her hand function recovers so well. We advise that there are further options for tendon transfer for possible better hand function, but the patient is satisfied with her current hand. Sorry. Considering the outcome of the brachial plexus repair, a study from my friend Andres Maldonado and from his team at Mayo Clinic, Dr. Spinner, to provide us an insight that overland transfer is the operation that gives the best functional outcome, ranging from 75 to 100%, followed by Lee-Schwing-Wong procedures, and followed by tendon transfer. The nerve graft is still have a role in C5, C6 nerve injury, especially in pediatric patients. So in summary here, in adult, the time to surgery and the surgical strategies are the only factors that can be modified by the surgeons. So it would result in the patient outcome, and nerve intervention more than 6 months after the injury rarely result in meaningful recovery. So do it at the right time, choose the right procedure for the patients. The renovation priority mainly aim mainly to restore the elbow flexion and shoulder abduction. The renovation of hand function might be possible with the techniques of the nerve transfer and the tendon transfer. The repair strategies depends on the injury patterns. And for now, the nerve transfer is might be the viable option for preganglionic lesions and for the lower brachial plexus injury. So thank you.
Thank you, Jake,
Yeah.
for this great presentation. Any questions, comments from the panelists to Jake? Hesham, please go ahead.
Thank you, my dear friend, for this excellent presentation. I have a couple of questions for you about nerve transfers. Do you use phrenic nerve in your procedures? And the other question about the contralateral C7. What is your experience about it?
I use phrenic nerve for reconstruction because especially in patient with total brachial plexus injury, because we use this a lot in Asia patients because the patient usually young and thin. But I think in the US or in the Western country, phrenic nerve is not that popular because there are risks of maybe diaphragm function or so. But usually I do the respiratory test, I mean the lung function test before taking the phrenic nerve. If the patient is young and thin enough and the lung function test is good, yes, I take phrenic nerve to use as a donor. The contralateral C7, I rarely use it. Usually I preserve that for maybe the free functioning muscle transfer if the primary nerve repair failed. So there is something spare for the free functioning muscle transfers.
Okay, thank you. Thank you.
Thank you.
May I ask one question, Professor?
Yeah, sure.
Thanks, Professor, for a very nice presentation. I want to know whether now voluntary exercise, does it really help in terms of the nerve regeneration? Thank you.
Voluntary exercise. I think Dr. Shandan will talk in cerebral plasticity in the next session. This is very important because usually after the nerve repair, we try to do the exercise, and usually the voluntary exercise, yes, is would affect the outcome of the nerve repair. Sure. Yes.
Thank you, Professor.
Yeah, I'll talk about it in my next presentation. So one question to Jake is till what age in adults would you do? So same question which we had discussed with Esham. Like what is the upper limit? How old the injury can be for you to do the nerve transfer? Like how long can you wait after the injury?
I mean, in adult.
Yeah, in an adult.
In the adult, I usually, if it depends on if you clarify as if the patient got the preganglionic injury. If you are sure that the patient have the preganglionic, I don't wait for so long. Maybe usually the time after the MRI and everything maybe take 2 to 3 months. I do the operation maybe in kind of 2 to 4 months. But in post-ganglionic, usually I wait 6 months.
Okay, no, so a patient is neglected, patient comes to you, say 1.5 years after the injury, would you still offer? Uh,
Uh,
so what is
no,
your
no,
upper limit? So what is your
no,
upper
no, no. Oh, my upper limit 1 year.
1 year?
1
Okay,
year.
okay.
After 1 year, I do not do the nerve operation. I referred it to my friend's plastic or orthopedic surgery to do the tendon transfer.
Okay, thanks. Thanks. I think any other questions from the panelists in the chat?
I think I have one comment. I think we can do surgery up to 1.5 years, and some authors say 2 years. I know the results are modest, but the patient has nothing to lose. You can give him the chance, especially for shoulder transfer, spinal accessory to suprascapular. It may work after 18 months. I think you should. I myself give the chance to the patient up to 2 years, but I have to inform him that the results are very bad.
Yeah.
But global policy, the results always are bad. So the patient can take the chance, especially for the shoulder, in my
Yeah,
opinion.
I have few cases with kind of quite young, 12 years, 15 years. Yes, I do the delay nerve repair for them too.
I
Okay.
think Gavin has a question. Gavin, yes.
Yeah, great
Yeah,
talk,
hi,
Jake.
Gavin.
Really liked it. Patients with brachial plexus injuries frequently have chest injuries with fractured ribs, and that has a big impact on using the phrenic nerve and the intercostal nerve. What preoperative testing do you do with the intercostal nerves and phrenic nerve in the setting of patients with fractured ribs?
I do the pre-op inhalation and exhalation chest X-ray to confirm the contraction of the diaphragm first thing. And the second thing, I use the a pulmonary function test. Usually I do not offer the phrenic nerve or the intercostal nerve in patient with chest injury, because you don't sure if the patient got any injury of those nerves, and you can make sure if you cut the phrenic, the patient can withstand with the losing of the one diaphragm. I cannot make sure of that. Taking the phrenic and intercostal in chest injury.
Thanks. Thank you, Jake.
Yeah, thank you.
Start with the next presentation, which is my presentation on plasticity. I hope you all can see my screen. So first of all, thank you very much to ACNS and WFNS for this opportunity. I'll be talking about central plasticity nerve injury, which is somewhat of a theoretical topic, and there are a lot of myths and misconceptions about this. But interestingly, so greetings from Mumbai, and so the plasticity, there is a lot of interest in plasticity in general public, because there are now books on plasticity, how to use neural plasticity in terms of maximizing your memory, maximizing your other skills. And there are a lot of there is a game on Nintendo as well for brain training, which was by Dr. Kawashima's program as well. And now there is a journal of neural plasticity. So neuroplasticity is a very evolving field, and a lot of interest in that. But unfortunately, there are still a lot of misconceptions amongst our neurosurgical fraternity. So I just wanted to go ahead and give a broad overview of the role of plasticity in nerve injuries. So when you look at plasticity, it's basically what happens over a period of time after repetitions and training is that the cortical activation area progressively becomes smaller. The excitation of the cortex, which is more widespread in the initial half, becomes narrower, so there is more inhibition. And so an expert is able to activate only a small focal part of his brain to do the same activity after a number of repetitions and learning. So I've written about this a few times in the past, and one of the important things about central nervous system plasticity is that it is rarely covered in the standard textbooks of neurosurgery, or for that matter, even peripheral nerve surgeries. And most of the surgical residents and trainees are not acquainted that there is a role of plasticity, and there is a role of plasticity in the role of peripheral nerve regeneration, which actually generated this interest for me to write about this topic. So plasticity actually is not a very recent concept. It's been there since more than 100 years. So Jones first described plasticity as the adjustment in the nervous system to any change in internal or external milieu. Plasticity, the role of plasticity is very well established in other fields like stroke, aphasia, vision, memory loss, chronic pain symptoms. In the landmark paper of Narakas in 1984, he actually speculated that there is a central role uh, in the success of nerve transfers. So let's cover this topic in trying to answer these questions in true or false, and then discussing each of these small questions in some detail. So does plasticity occur only in the brain or in the cortex? Plasticity, is it a slow and a long process? Is plasticity always beneficial? Does plasticity only have theoretical implications? There is very little clinical or bedside transition of this knowledge of plasticity in nerve injury. Is plasticity permanent or is it temporary? And does plasticity happen only in children and doesn't happen in adults? So let's take all of these questions one by one and answer them. So does plasticity happen only in the brain and cortex? No, the simple answer is no. It happens at all the levels of the central nervous systems. So the plasticity can be both structural as well as functional. So structure means there is a change of the anatomical substrates, and functional is when we are looking at more synaptic connections being formed. So you can see that plasticity occurs at all the levels of the central nervous system. It occurs at the level of the injured nerve, at the levels of motor neurons, spinal cord, thalamus, brainstem, as well as the brain cortex. So this is one of the main myths in plasticity, that when you think of plasticity, you just think of the brain and you don't think of anything else, but that's not true. So this is in fact a very nice paper which actually said that the brain is malleable. It's a malleable brain because there is a lot of factors which affect plasticity, especially motor skill learning, associative learning, development, so environmental as well as the innate or structural changes which are happening at the molecular level as well as anatomically. So let's go to our second question. The second question is plasticity a long and a slow process? So that's again is a myth. Plasticity is not a long and a slow process. And in fact, plasticity has been recognized that it can happen immediately and it can have long-term implications. So for example, if you cut a nerve, and you do a cortical map of the experimental model before and after, you would see that the cortical maps are changing as soon as you cut the nerve. So it happens within minutes of the nerve injury. And when you look at it from a molecular perspective, it's basically because of the unmasking of the latent synapses and the GABA inhibition, which reduces. Over a long term, during reinnervation, you see processes like long-term potentiation, long-term depression, new formation of synapses, and axonal sprouting. So this is very famously seen in multiple papers. It's one of the landmark papers which came from my institute as well, is in the intercostal and musculocutaneous nerve, where initially the biceps control is in the intercostal area after you do the grafting. But over a period of time, this biceps control shifts back to its normal area, which is the biceps area in the brain. And this was shown very nicely in an fMRI study I'll show in a couple of slides. Then the other thing is that plasticity also tells us why some nerve transfers work well and why some other transfers don't work well. So for example, when you look at an Oberlin's repair, which is basically the transfer of the ulnar nerve fascicle to the musculocutaneous nerve, obviously there is the number of axons which are almost equal in both the donor as well as the recipient, but also because of the fact that the elbow area and the hand area are very close to each other in the brain. So there may be some amount of interneurons which are already present there and which gets unmasked and helps us to give very good results after an oval limb repair. Another example is the use of the hypoglossal nerve as a donor. So if you use the hypoglossal nerve as a donor for musculocutaneous nerve transfers, the success rate is very low. It's only about 20%. However, we all know that hypoglossal nerve, when it's transferred to the facial nerve after CP angle surgery, the success rate is as high as 92%. Now, one of the reasons, along with the other reasons, is the fact that the hypoglossal nerve actually is quite close. The hypoglossal area is actually quite close to the face area. And that might be one of, so you can see it from the cortical representation map, that this might also be one of the reasons. I'm not saying that is the only reason. This is definitely one of the reasons that why you see better results after hypoglossal to facial nerve transfers. Now, how do you evaluate cortical plasticity? So we do not have a direct way to measure cortical plasticity. So we evaluate it in multiple indirect ways. So we do a PET scan. So PET scan will show an increased blood flow. With increased blood flow, you assume there is more neuronal activation there. Same thing with fMRI. You again look at look at blood flow. You also can do structural MRI where you can measure the volume, the density, and the thickness of the gray matter, and then comment how the gray matter is changing before and after. You can also do a DTI imaging, which is basically diffuser tensor imaging, which looks at white matter tracts and the integrity of and how these white matter tracts change. So this is a really nice paper again from our institute, which I alluded to in my previous slide. So this is one of the patients who had basically an intercostal to musculocutaneous nerve transfer. Here you can see that there is no activation of the elbow area on the repaired side, and this patient obviously did not have any clinical recovery. But at the same time, another patient who had a good grade 4/5 recovery, you see the activation of the cortical area in the elbow area after the intercostal to musculocutaneous nerve transfer. So there is this anatomical substrate as well, which I was talking to about, which you can pick it up on a study like fMRI. This is the same thing. So intercostal to musculocutaneous, one of the hypotheses is that there is an existing interneuron connection between the biceps and the chest area, and this interneurons basically get over a period of time, they get unmasked, and that's the reason why after intercostal to musculocutaneous nerve transfer, initially the biceps is controlled by the intercostal area, but over a period of time, this control moves to its normal elbow area because of these interneurons which get unmasked. So the same principle is why some of the nerve transfers between antagonists work well. So again, now let's go to our next question. Is plasticity always beneficial? Simple answer is no, because there is something called as a maladaptive plasticity. Is very common, especially most of you might be aware of in the phantom limb or the phantom pain, patients with neuropathic pain. So patients who have neuropathic pain, it is noted that there is basically cortical reorganization in the sensory cortex, and that is what is one of the important causes of pain. So even if two patients who have very similar injuries, but one of them is having severe intractable neuropathic pain after a brachial plexus avulsion injury, for example, and other patient is absolutely fine without any pain. So what is the reason between the presence of pain in these two patients is because there is cortical reorganization in the sensory cortex, which is maladaptive. So another question, if we look at it, is plasticity permanent? Is it a focal event? Does it happen in only one area of the brain? So simple answer is no, it is not permanent. And for example, we do not have any direct data from nerve surgeries, but what we have is from other specialties. So there were patients who had painful osteoarthritis of the hip, and it was noted that all these patients who had painful osteoarthritis of the hip had a contralateral atrophy of the thalamus. As soon as the surgery was done, the pain was relieved, this thalamic atrophy reversed. Same thing was noted in the cingulate, prefrontal, and the insular cortex. Within 6 weeks to 4 months, you can actually note the reversal of atrophy. So that again tells us that plasticity, even though it may appear structural on your MRI, it can over a period of time reverse. Now, as I told you, plasticity is not a focal event. It happens at multiple areas of the brain. That's one of the reasons. Let's look at one of our common examples, the contralateral C7. So this was an experimental study, a very nice experimental study, in which it was noted that 5 months after a contralateral C7 study, if you do the fMRI, it's the ipsilateral cortex which moves the injured limb. After 10 months, stimulation of either cortex, so you can do the right side or left side, it will still move the injured limb. But after 16 months, if you stimulate the contralateral cortex, it's again moving the injured limb. So how did the contralateral limb get contralateral limb get back the control of the injured side? That's because you have to remember that the corticospinal tract, we always think of corticospinal tracts crossing, but there are about 10 to 20% of the corticospinal tract fibers which do not cross. And since they do not cross, and over a period of time, especially when you do a contralateral C7 procedure, these fibers, the 20% fibers which were not crossed, which were not generally more functional, they get unmasked. And that's how the injured side or the contralateral cortex regains the control of the injured side. Now, what is the use of what is the use of this knowledge of plasticity in rehab? So, for example, this is actually, we have level 1 evidence to show that constraint induced movement therapy, in which you basically limit the movement of the normal side and you promote the movement of the other side. So, for example, we do it commonly in brachial plexus injuries in children, the neonatal brachial plexus injuries in children. What we tell the patient is to basically keep the hand tied of the kid after the normal hand has to be tied, and new toys or new things which the children like to play with, they are introduced when the normal hand is tied. So what happens is that the child is forced to use the nerve injured hand to explore and to play with the new toy. And that is again a very, very good mechanism of enhancing synaptic plasticity. And this increases the glutamate receptors in the sensory motor cortex and help in recovery of the injured brachial plexus. So this has already been used in stroke and cerebral palsies, but now increasingly being used in neonatal brachial plexus injuries as well. Another thing is sensory re-education. So now it is very important that you give some sensory input from a nerve injured area so that the cortical maps reorganization happens. So this is a very nice, again, an experiment in which basically this is a sensor glove. So this sensor glove is basically transferring the touching movement into sound, and these sounds are basically put on the through the headphones. So whenever you touch a new object, whether it's soft or hard, smooth or irregular, you basically stimulate the glove. The glove transfers this sound, stimuli into sound, which goes into the brain. So even if the nerve is completely injured, you still have some input which is going to the brain whenever you are using the hand. And this helps again in helps in localization and 2-point discrimination, especially useful in nerve injuries of hand. So improved motor function again is dependent on sensory input, and exercises again are very important because it keeps your cortical map organized. It makes sure that there is no reorganization, there is no infiltration of the surrounding normal areas into the cortical map. So that is one of the reasons which Professor Liu asked as to why exercise helps after nerve injury. The exercise helps in nerve injury is because it maintains the integrity of the cortical map and prevents the reorganization of the cortical map. The last question is, what does plasticity happen only in children? It doesn't happen only in children, but definitely plasticity is much more prominent in children. It's much more prominent in infants and children compared to adults because they have better regeneration potential and shorter regeneration distances. But also, the infants have better restoration of the cortical maps. I think this was one of the factors which were missing, which we were not aware of, but the primate studies have showed that the cortical restoration of maps is much faster in younger individuals than in older individuals. Now, there have been some drug therapy which we know which may not have been directly related to the field of nerve injury, but generally there are medications like dopamine or ketamine which are known to stimulate neurite growth factors, synaptogenesis, and there is a possible use of these medications in improvement of nerve injury as well. So our current challenges for plasticity as far as nerve injury is concerned is that majority of the data is actually not from nerve injury or regeneration. And a lot of data is still coming in from rodent models, rats, the monkeys, primate data. And all the methods that we use to measure plasticity like fMRI, DTI, TMS are all surrogate of plasticity. They are indirectly telling us that there is plasticity involved. We do not have a tool to measure plasticity directly, and therefore there are some limitations of these imaging techniques. There are a lot of unknowns as to why nerve transfers work in the antagonist in the lower limbs. We're still not sure as to why it works in the lower limbs. So it's still evolving in multiple waves. I think that is one of the challenges of direct application of plasticity in nerve injury patients. So in the future, we're definitely looking at individualized treatment and rehab protocols, which may involve direct motor cortex stimulation. Closed loop vagal stimulation has also been shown that it improves function, especially in stroke patients, and there are already some early papers that it may be useful in nerve injury cases as well. We need more level 1 evidence, obviously, especially for rehab protocols. A lot of rehab protocols are still not standardized, and there is multiple variations in rehab of these patients, which may become better once we have more level 1 data. There should be refinement of radiology technique that will help us in understanding of plasticity. There are now radioactive tracers which are tagged to neurotransmitters like acetylcholine in PET scan that will help us to understand the pathophysiology of synaptic plasticity. There is a lot of research of plasticity in other fields of like stroke, aphasia, memory, so possibly there will be some transfer of knowledge to our field as well. So my take-home message, plasticity occurs at every level of the central nervous system. It can be useful, it can be harmful. Plasticity also tells us, at least in some cases, that why some nerve transfers work very well while others don't. Mechanism is usually the presence of interneurons, unmasking of the previous pathways and synaptic plasticity. Patient-specific rehabilitation may be possible very soon, and we probably are looking at a lot of the basic science data coming over to the clinical side and giving us good patient outcomes over the next decade. Thank you. Thank you so much. Any questions from the panelist audience?
Thank you, Professor Chandran. I have two questions for you, Professor. One is, beside drugs that you mentioned that may enhance plasticity, what do you think that related, any evidence related food or environment that may help in plasticity? My second question, Professor, and how do the current technology that are available, they're able to help in terms of accelerate the plasticity, for example, like the use of brain chips or neural link or TMS in this? Thank you, Professor.
Yeah. So let me let's talk about the newer things like the neural links or the brain chips which might come. So as I told you, somehow nerve injury as a field has been one of the lower priorities as far as plasticity is concerned. So most of the focus for the plasticity data has been in stroke, memory, aphasia, blindness, phantom phenomena. But and probably then you come down to nerve injuries. So by the time it gets refined and filters down to nerve injury, we are still looking at probably a decade or so. I would that's what it will happen, because if it works in one, it can definitely work in the other way as well, hemiplegia and things like that. So, but we still don't know whether it is. I don't think it will. By the time it trickles down to the field of nerves, it's going to take time. It's going to take much longer than the other. And can you repeat your first question? I just forgot.
In whether nutrition or food or environment do help in terms of plasticity besides drugs that you mentioned?
So unknown. So we don't know that whether there is some diet or food this thing as far as plasticity is concerned. So the problem is whenever we, even if there is a drug or a new medication which comes in and helps you, we do not know whether it is directly affecting through the mode of plasticity or some other mode, because plasticity itself is measured through indirect ways. We do not have a direct way to measure plasticity. So for example, when we do PET scan, we look for increased blood flow in that part of the brain, right? So, and then we are assuming because there's increased blood flow that area neurons are getting activated, and hence that there is some plasticity which is involved. But it's again indirect. So we haven't got that data from the basic sciences part to really say with certain amount of confidence that there are some nutritional factors or drugs which will directly change the plasticity and then directly change the outcome.
Thank you, Professor. Professor Ferry?
Yes, thank you. Dr. Chandan, I would like to ask, what is your opinion about visualization? Does it has a role in improving cortical plasticity in terms of improving the outcome in patients with peripheral nerve injury as well as in patients with chronic pain?
Yeah. So visualization is an important thing. So I did show you in the slide about mirror therapy, which is very commonly used in phantom pain. It also has a role in post-avulsion neuropathic injury. So basically what it does is it keeps the cortical maps in an organized manner. Because what happens is that if you have infiltration of the surrounding areas into that cortical area, that is what is so known to be as a substrate of, especially for phantom pain. And definitely visualization helps. I also told you about the auditory stimulus, the sensor glove. So I think stimulus in any way can be useful for cortical plasticity. The exact pathways are still not known, but there is enough data, at least from other fields, to show that yes, all types of extra stimuli, whether it is tactile, whether it is auditory, whether it is visual, will help in restoration and regaining of function.
Thank you, Dr. Chandan.
Esham, I think you had a question.
Thank you so much for your comprehensive presentation. I have a couple of questions for you. The first is, do you think that brain plasticity plays a role in cases of tendon transfers when you use extensors for flexions or other procedure, so the brain plasticity can work on this? The second question about deafferential pain. In global palsy, we have severe pain in this patient, and do you think that our surgeries for reconstruction can reduce this pain? Thank you.
So, as far as tendon transfer is concerned, whether it really affects plasticity, I'll be very honest with you. I have not come across any papers which are looking at muscle transfers or nerve transfers changing plasticity. So I don't know the answer. This very simple question. I don't know the answer for that. As far as your second question is concerned, whether nerve reconstruction has a role in reducing the avulsion pain, the chronic neuropathic pain is concerned, there is data actually to tell that patients who undergo repair have less pain, avulsion pain compared to patients who are not operated. The reason, again, as I told you, is even if clinically those patients do not improve, there is restoration of the pathways. And that may be maintaining the cortical maps in a certain way, and that may be reducing the chronic avulsion pain once they are operated. Even if the patients do not recover clinical function, we have seen that those patients have reduction in their chronic neuropathic pain. even after surgery, even after failed motor recovery. So there is some evidence that once you reconnect the end organ to the brain, there is pathways which open up and which reduce the pain.
Thank you so much.
So thank you so much. I think we'll move on to our next speaker, that is Professor Ferry Sanjaya. He will be talking about reverse end-to-side transfers of distal AIN to motor fascicles in severe cubital tunnel syndrome.
Yes, thank you for the time. Wait, let me okay, can you see my screen now?
Yeah, we can see your screen, Professor Ferry. Please go ahead.
Okay, thank you. So thank you for the time for me to present this with all of you, distinguished speaker. So I'd like to present a reverse end-to-side transfer of distal anterior interosseous nerve or AIN to the ulnar motor fascicle for severe cubital tunnel syndrome. Wait. It's a problem with my presentations. Okay.
Can you exit and restart again? I think.
Let me try to restart again.
Yeah. You can just stop sharing and then again go for sharing and start.
Screen freezes on me. Let me try to log out and then we'll log in. I don't know. My screen is freezing on me, so.
Okay. So,
let me see.
Just log out and then log in again.
Yes, or maybe if it's okay with Dr. Rob Spinner, if to start first, and then I'll do the wait. Are there?
Oh, we can see it now. Yeah.
Oh wait, here it's coming back.
Okay.
Let me try again.
Yes.
Wait. Still not working. So I'm sorry for this. Maybe if you can start with Dr. Spinner first, and then I'll try to log out and then log in again.
Sure. Please do that.
Okay with Dr. Spinner.
Professor Spinner, are you okay with that?
Sure.
Okay, great.
Okay, that's great.
Well, good morning from here. It's 2:30 in the morning here in the U.S. It's a pleasure to be here. I'd like to just talk to you about a different topic, just nerve tumors, which has been a hobby of mine over the years. I'd like to really just present a paradigm, how to consider the diagnosis based on some easy pattern recognition. You know, I think we're all used to identifying patterns, whether it's with cards or with tumors, it's really the same thing. And there's really a very straightforward way of approaching patients for the most part, but we'll talk about the future. I think obviously understanding tumors is important for your patients and for the ultimate treatment implications. You know, we're going to just switch a few things over the next few minutes. But, you know, the bottom line is we all see the most common nerve tumors, schwannomas, neurofibromas, and for the most part in the periphery, patients present with some symptoms, but they typically don't have a major motor deficit. And then the MRI findings are really quite classic. They'll have a fairly round tumor within a nerve. So here's a typical case of a patient presenting with calf without back pain, with some radiating paresthesias into the plantar foot. The exam is normal, the EMG would be normal, and the patient has a round tumor here in the tibial nerve in the proximal calf. If it's symptomatic enough, you could explore it, and proximal is here, and take out the tumor in a standard fashion, finding the entering and exiting fascicle. And I think when we think about schwannomas or neurofibromas, really it's a simple operation for us where we're trying to find things go in, go out with little damage to the intrinsic nerve itself. And I think the results are quite favorable with about a 90% chance of saving function. Now, if you have one tumor, then all of a sudden, instead of benign nerve sheath tumor, you can add an S, and it's benign nerve sheath tumors. And patients, again, may have nerve symptoms without a fixed motor deficit. And now, instead of a single mass, you'll have several masses. And we'll just say, for this example, that they're on different nerves. And if you have several nerve tumors, then you most likely have some syndromic element. So here was a patient with this scan who was told that they had metastatic disease. In fact, this is an early patient of schwannomatosis. And here, symptomatic lesions involving the right brachial plexus were taken out. And here's the lower trunk lesion. And here is another lesion on C6 that was left behind. And the patient over the years has presented with numerous tumors. They were found to or thought to have piriformis syndrome until they were imaged, first on the right side, then the left side. And of course, we all know that with schwannomatosis, the intracranial elements can be affected, but less so. And here's a trigeminal schwannoma that's received gamma knife. Schwannomatosis in general doesn't affect the acoustics. In contrast, as neurosurgeons, we're all very familiar with NF2 and the acoustic nerve tumors. And I would submit that the NF2 tumors that affect the acoustic nerves are much more complicated and in fact have some more plexiform type of elements. And that would explain why the tumor surgery is less effective and the outcomes are less favorable than with standard acoustics. But NF2 patients get schwannomas in the periphery less commonly, but these are very complicated tumors. These are not the standard round globular mass. In fact, you can see it appears like a sheet rather than just a simple round tumor. So all schwannomas are not the same, and here's a patient with a plexiform lesion affecting affected fascicle or fascicular group, and this is not your typical schwannoma. So when you're reading about round tumors that are schwannomas, don't just assume that they're all the same. Now, NF1 is much more common, being 1 in 3,000 rather than the 1 in 30,000. And we're all familiar with people with external tumor burden that may or may not correlate with the internal bulk. And for in general, the deeper tumors, it's often hard to tell what's benign and what's malignant. Now, we'll all see lesions like this where they'll have plexiform neurofibromas, but the patient presents, let's just say, with pain and some paresthesias. And you have to make a presumption that it's the bigger tumor and perhaps the one that's growing. Obviously, you'll have to think about whether or not it's benign or malignant, but many of these are just a predominant plexiform neurofibroma that's benign, and you can take that one out, leaving behind the rest of the nerve bulk, which is all tumor. And in fact, many tumors are seen in this patient with NF1. And then there's certainly those tumors that are not resectable. And when you get this referral, obviously there isn't very much to do for anything. Now, switching from tumors to lesions, those tumors were really round masses. We all are getting much more familiar with lesions, which are either tubular or affecting the whole contact of the nerve. And patients will present with symptoms, and now they'll present with a deficit and get imaged. And instead of just a round mass, they'll have some other lesion. And as surgeons, we're often asked to interpret even better than some of the radiologists. So I wanted to talk about some lesions now that are not masses and are not tumors per se, and these are tumor-like masses, and these include this range of elements: ganglion cysts, intraneural perineuromas, various lipomas, and then congenital lesions, including hamartomas or chorostomas. And I think what's becoming quite evident is their clinical pattern is recognizable, and their imaging also is radiologically interpretable by surgeons. And I think that's critical. So we're all very familiar with the foot drop, and I would say anyone with a progressive foot drop needs to be imaged. I think the imaging often can show, as we've seen in this study, about 20% of patients with peroneal nerve palsy that present for EMG have an intraneural cyst, and this cyst doesn't have to be big like this one. It can be relatively small. And I think over the years, we've appreciated now that there's no solid component. This is all fluid, it's all cyst. So therefore, it's different than a cystic schwannoma, which still has a solid component. But in addition to the typical schwannoma, there's nothing here that looks like a cystic schwannoma. This is following the course of the nerve in a tubular fashion. And I think what we've learned over the years is that these are all connected to a joint. And if you don't see the joint connection, it's because the imaging is missing that section. But if you were to reformat, you could make a continuous type of pathway. And for the peroneal nerve, if you look at the articular branch, it will be affected. In this example, you can see how large it is versus a cadaver limb, where it's following the same U-shaped course. So there's a very good anatomic explanation for these intraneural ganglion cysts. And of course, that's led to the theory and now probably a law showing that these are all joint connected and that the extent of the cyst relates to the pressures and the path of least resistance. And the surgery has gotten much easier, particularly if you recognize the cause. So the surgery really can be very easy and directed towards the articular branch. You don't need to resect the cyst. You can disconnect it and then just drain it. And what occurs at the peroneal nerve really is the answer for all of these cysts. There are articular branches at all of these sites, even the rarer ones that you may have not have known the articular anatomy. Now, in contrast, there are other lesions that present now with symptoms, deficit, but the deficit may be slowly progressive. And again, instead of a tumor per se, there's a tumor-like lesion. I think the most common that we've seen over the years and the most common one talked about are the intraneural perineuromas. And I think for the most part, these have a very classic history. It's progressive motor weakness affecting adolescents. Now, last week I saw someone who was 8 years old. But in general, these are young patients, and they're bothered by this slowly progressive motor deficit. I think what we've appreciated is that the imaging, again, shows that it's a tubular lesion with a certain radiologic appearance. So here it may look like a mass, but in fact, the whole nerve is big and the fascicles are affected. And we used to biopsy it. So here's this ulnar nerve lesion, and I took a fascicle then to get a diagnosis. But we've shown over the years that if you have good imaging, the imaging features can tell the story. So here, just to make a plug for imaging, all imaging isn't the same. So here's the difference in the same patient with a tibial division problem of the sciatic nerve, showing standard 1.5 versus 3 Tesla. And this is a scan from more than 12 years ago. But you could see on 1.5 Tesla conventional imaging how poor it is versus the resolution with 3 Tesla. And there you could make out the diagnosis. There's no question that this is a intraneural perineurioma. And then 1.5 versus even higher resolution, we had the first MRI scan that's commercially available for clinical patients in North America using 7T, and you could see how beautiful the gadolinium enhancement pattern is. And this is classic for a perineurioma, especially in an adolescent with slowly progressive motor loss. So we're not biopsying patients with classic findings. Now, even rare situations where these are rare, you can still make the diagnosis without doing tissue biopsy, and you can predict a natural history. And hamartomas are normal elements within nerve. Carcinoma are abnormal elements in nerves. So hamartoma is typically fat. Carcinomas are something like muscle. Those shouldn't belong in nerve. But these now are young people progressing with neurologic findings and maybe a fullness or a mass. So here's a patient with macrodactyly. We've all heard or seen of these cases. The most common site, just like the perineal nerve for the intraneural ganglion, for lipomatous lesions tends to be the median nerve for whatever reason. And you don't need to biopsy or even think about it. This is all fat infiltrating a nerve, giving a large nerve. It's not a liposarcoma. It's not a tumor. This is never transformed into a malignancy. But for whatever reason, we've shown a pattern where this fatty nerve gives symptoms suggestive of carpal tunnel, is associated with lipomas in the nerve territory, and then can have nerve territory overgrowth. But this is no mystery. This is a pattern that needs to be recognized, and it's a distal overgrowth. We don't understand that, but it's present. You don't need to biopsy. So here you could release the carpal tunnel, don't resect the lesion. Now, on the other hand, you can have something else where a patient presents with undergrowth. And my esteemed colleague talked about neuropathy in the babies earlier tonight. And here it's the same type of undergrowth, suggesting a congenital lesion from nerve reasons, just like with the obstetrical palsy. And here you can see a 𝒂𝒊𝒏𝒄 foot. You can see the hypotrophy, the atrophy, and you can see it affecting the whole nerve territory of the sciatic nerve. And if you were to image the patient, the entire sciatic nerve is enlarged compared to the opposite side. Look at the difference in sciatic nerves. And if you were to explore this, and this is old, so this is 20 years, so I'm going to show now my learning curve. 20 years ago, I explored this patient, and I found this large nerve, and I made a comment that it looked red like beef, like a muscle, like a steak. And then, sure enough, we found muscle in it, in the nerve, and this is a carcinoma with undergrowth. But in fact, the MR features on not just T1, but T2 and enhancement, the patterns are suggestive of muscle. So now we're not biopsying it because we've learned that many of those patients, for whatever reason, develop a desmoid tumor in the nerve territory. So in fact, right where I biopsied that patient, the patient ended up with a desmoid tumor. And we've shown over the years that not only is this not uncommon, it's in the nerve territory. So stay away from that, identify it on imaging, and then make your diagnosis and treat the patient without increasing the number of fibroblasts. So it's all about patterns. The other benign tumor would be something pressing on a nerve, not intraneural, but extraneural. So here patients will present to the neurosurgeon typically with symptoms, oftentimes a deficit, And now there's a round mass, but if you look at the imaging, it's outside the nerve, extrinsic to it, rather than the intrinsic intraneural lesions. And the most common ones are the ones we talked about. The lipomas, the fatty tumors that are benign, the ganglion cysts, or anything else, bony tumors, whatever else. And there, the surgery is really quite easy. You protect the nerve and then take out everything that doesn't belong there. So the most common example would be something like the posterior interosseous nerve. So if you have an unusual site that you're thinking is entrapment or even neuralgic amyotrophy Parsons-Turner syndrome, where you get a PIN palsy, make sure you image the patient, because as in this case, with any imaging modality, you can see the lipoma on plain radiograph, on CT, and of course, a lobulated fatty lesion on T1 imaging. And there you get out the radial nerve and you take out the tumor. But it's extrinsic to the mass. All you need to do is identify everything and then take out what doesn't belong there. Now, finally, I think we all need to be very careful about this element and this lesion, because unlike the benign lesions here, if you know about a malignancy, you would treat it differently. And you wouldn't want to just quickly go in and resect the tumor. So here, most patients with malignancy present with increased pain, but they would typically have a neural deficit that's evolving with a rapid course, and their tumor would be growing under your eyes. A lot different than the pattern for a benign nerve sheath tumor. And if you look critically, most of the masses are not perfectly round. There's something unusual, and many, but not all, have increased avidity on PET scan. Now, we all know about the challenges with PET scan, and that's why we're doing other types of imaging. But for global neurosurgery, I think some of the newer MR sequences aren't being routinely done at all institutions, including some of the diffusion type techniques, etc. So a typical case of a malignant tumor in a patient would be a 52-year-old man with a new mass, severe burning pain, calling about opiates, progressive weakness in a relatively short fashion, and your exam would show a mixed nerve, for example, with motor and sensory deficits. And if you looked at the patient may talk to you about the mass growing. Here, the subtle thing is obviously the patient had unrecognized NF1, which raises your suspicion. But if you look at even the MR or the other imaging that was done, the MR is not classic for a benign tumor. It's not perfectly round. There's some necrosis. It looks like there's a little bit of a bite of the lesion there. This isn't typical. So based on those features, I would recommend that you do a percutaneous biopsy in this patient and not just take out the lesion, because many people would do different treatments for this patient. The first being staging them. So here I staged with a PET CT. You can see the avid lesion, but there are no other lesions. We've all heard of patients being treated for a single lesion who subsequently were found to have widely metastatic disease. And I would tell you that the big operation that the patient received probably wasn't the treatment of choice, because now you were going into a more palliative type of approach if you knew there were widely metastatic diseases. So the approach to a malignant peripheral nerve sheath tumor is completely different than the benign. So I would say, based on the clinical and the radiological features, suspect it, then stage it, then consider biopsy, because if you knew something were malignant, you would treat it differently, whether with upfront treatment, and I would defer to our colleagues in oncology, but certainly you would talk to the patient about a different operation. And there, it's a multidisciplinary approach. And I just wanted to make sure that we're all thinking now, because Jake gave such a nice talk about nerve transfers, about some type of reconstruction, because patients are living longer, and oftentimes there are things that you could do, including nerve transfers. So peripheral nerve surgeons need to be part of the oncological team, even if sarcoma surgeons are doing the resection. So patterns are here. It's up to us to recognize them. If you put your head in the sand and you don't think about them, you're not going to recognize them. If you look, then together we can find these patterns. Now, there are going to be other agents that are going to help us, including AI. A lot of what we're doing now with breast cancer and benign versus malignant can be done with machine learning. So we need to think outside the box in order to make some of these answers easier, so that as surgeons, we have more information even up front. So in summary, I would just say it's not the cards you're dealt, but how you play your hand. Thanks very much.
Thank you, Professor Spinner, for that wonderful talk. Do you have any questions from the panelists?
Yeah. May I ask two questions, Professor Spinner?
Sure.
Yes. Thanks for a wonderful presentation, Professor. May I know that if you have a patient with lumbar plexiform neurofibroma, which you think is benign, over time you follow up and the patient have a progressive pain, and you may think the pain is due to instability caused by enlarging tumor. So what is the treatment available? My second question, Professor, and when will do a biopsy? When will you suspect a malignant transformation? Is it due to the rate of the growth of the lesion or due to irregularity changes of the tumor, Professor? Thank you.
So thank you. So for the first question, obviously the plexiform neurofibromas in an NF1 patient are difficult. The question really would be is putting together the history, the pattern. So in addition to pain, which obviously is worrisome, is whether or not there's some radiological change. So if you had just a studying of multiple small tumors, there wouldn't be anything you could do to biopsy, because which one are you going to biopsy? And in the lumbosacral plexus, as per your question, that's not an easy place to get to. So you're not just going to go and, explore. So you would follow that patient, and then if a lesion enlarged and or the clinical course got worse, then you would have a heightened suspicion. Now, during that time, you might consider other things like a PET scan. So you have to use all of the tools. The second thing was really related to, who do you biopsy? Well, I showed these two examples of a benign, which is one side, and then the malignant, which is the other. So, we all know from our literature that if something is a benign tumor, you probably shouldn't biopsy it, because the chance of false negatives and the scarring and the nerve damage and the surgery getting harder all exist. And we also know that for an obvious malignant one, you probably should biopsy, because there you don't want to have tumor spill. You want to know the diagnosis before you treat it, so that you can give upfront treatment, or you do the right operation and you counsel the patient. The reality, though, is that patients don't come to us with diagnoses. So there's always something that's a little atypical. So this week I took out a tumor in a patient where the PET scan had an SUV of 8. And all over the radiology was, we are worried about a malignancy because the SUV is 8. Well, we all know that schwannomas can have SUVs that are 8. So in a patient without a clinical history that's worrisome, and with MRI surveillance over several years showing only 1 millimeter of growth, I took out the tumor. But I would tell you that that patient would be in the middle. So where AI is going to help is not with the clearly benign and not with the clearly malignant. We can do that with our eyes closed. So in fact, when I get a phone call about the intraneural perineurioma, I can almost diagnose it without seeing an image, because I'm listening to the pediatrician and they're telling me it's a 12-year-old with a short leg and the foot has lost function over the last 2-3 years. And they see something on the MRI scan. Most likely, with that history, it's a perineurioma. Where we're imaging and AI is going to help us is with the gray zone. It's the person with some pain and the lesion is growing just a little bit faster. So there are many patients where cysts grow and it's completely benign. But when a solid tumor grows faster than you think is good, you really have to be worried. So there are many factors, but it's really based on patterns. Thank you.
Thank you, Professor.
Do you have any other questions from the panel? May I ask one question to Professor Spina? So do you routinely use monitoring for nerve tumors, or that's what is your protocol for monitoring?
Yeah, so obviously this is controversial. For routine medium-sized tumors that I have good proximal and distal control, I don't use monitoring. T.J. Wilson, one of my fellows, did a beautiful study showing that there wasn't any real statistical benefit to it. Now, on the other hand, I like to have monitoring available with tumors where I use access surgeons. So in the pelvis, for example. So we did a femoral nerve tumor the other day, and I like to be able to listen to myotonic discharges when I don't have perfect proximal and distal control. So big tumors, maybe big brachial plexus tumors, where you cannot see quite as well as a small peripheral tumor, I like to listen for myotonic discharges. I don't use SSEPs, I don't use NAPs, I just listen for EMG discharges.
So, do you prefer it over neurofibromas over?
Nope, and in fact, most neurofibromas that I take out are quite similar to schwannomas. And with NF1 patients, for the routine globular tumor, I wouldn't. That's a good question.
Thank you.
There's no right or wrong answer, though. So I just map the tumor visually, and every once in a while, I'll just show the resident how I'll map with disposable stimulator, just like we do for nerve transfers, but nothing fancy.
Thank you. Thanks a lot, Dr. Spina. So I'll ask Professor Sanjay Ferry to continue with his talk.
Okay, thank you. Let me try to share my screen again. Can you see my screen now?
Yes, we can.
Wait. I'm still experiencing the same problem. I don't know.
Can you play it over a PowerPoint rather than I think
yeah. Wait.
check your format maybe. Might be related to.
Let me try to. Okay, let me stop sharing first. I'll change the format to PowerPoint.
Okay.
My apology. Wait.
And then, is it possible for the speaker to mail the PowerPoint to any one of us so we can play it from our side?
Yeah. Professor Sanjay, can you just email that to maybe the ACNS team so that they can play it from their end also?
Yeah, let me try to. I already exported to PowerPoint. Let me
Okay.
try to
Yeah.
share my
Try the
screen.
PowerPoint variation. Otherwise, you can just show the slides without going into slideshow. You'll have to keep that same.
Yeah. Right. Yeah, this one should work. Is it working now? Can you see my
Yes.
screen?
Yes.
Yes.
Yes. Yeah, I think it's the format problem. My
Yeah.
apology. So I'm going to talk about RATS transfer, reverse antecedent transfer of anterior interosseous nerve to the ulnar motor fascicle for severe cubital tunnel syndrome. We know that cubital tunnel syndrome is resulted from chronic compression of the ulnar nerve while passing through the anatomical tunnel at the elbow. There are three compression site at the retrocondylar groove, as well as under the Osborne fascia and under the flexor carpi ulnaris. And also frequent flexions of the elbow is also one of the mechanisms that causes this condition. Oh no. Oh, okay, wait. It's not working again. So let me try to email this to
Just click on the main screen. Just click on the main screen.
wait. So maybe I'll just open it without
the slideshow. Yeah. Yeah.
like let's try. Sorry. Oh wait.
Yeah, you can show it like this if
Okay.
yeah.
Sorry.
No, it's okay.
Mostly, it's insidious in onset and progresses slowly. In some cases, it can present itself in a relatively acute onset with faster progression. The symptoms and signs of ulnar neuropathy, patient can present with hyposthesia and paresthesia and the distributions of the ulnar nerve. And in more severe cases, we'll see wastings of the ulnar intrinsics with ulnar plowing, Wartenberg signs, and also Frohman sign. The typical surgical management, simple inside decompression. I do this type of procedure, and also anterior transposition, either subcutaneously, intramuscular, or submuscularly, and also medial epicondylectomy. For chronic and severe cases, prognosis following surgery with regards to motor recovery has been very guarded. Molavi et al. Shows that the surgical outcomes for mild to moderate ulnar neuropathy is quite good, and for severe disease, usually the result is quite poor. The goal of surgery has been to halt the disease progression and to preserve motor functions and sensory recovery. So the question raised is there anything else that we can do to improve motor recovery and intrinsic recovery in this patient, at least in a subset of patients with severe ulnar neuropathy? In 2005, there has been some studies regarding reverse antecedent transfer, and the terms axonal supercharging has been coined by Isaacs et al. In 2005. They show in their study in rats transfer in the acute setting in sciatic nerve can augment and expedite reinnervation while allowing spontaneous recovery from the recipient nerve. The anterior interosseous to ulnar nerve motor transfer has been performed by McKinnon in 1991 in a patient with complete high ulnar nerve injury in an end-to-end manner. And later on in 2009, she described a reverse end-to-side transfer for a severe cubital tunnel syndrome. The RADS transfer can protect and preserve distal motor end plates until the native axons fully regenerate, and it does not obviate the potentials of the native regenerating axons. However, in cubital tunnel syndrome, because it's an injury in continuity and it progresses in a chronic manner, the onset of axonal loss is less clear compared to an acute injury. Therefore, we need to do a good patient selection to select the candidate that will benefit from this procedure. And EMG and as well as nerve conduction study has been shown to help us select this candidate. So reduced CMAP's amplitude as well as the presence of fibrillations in the hand ulnar intrinsics have been described as patients that might benefit from this procedure. So I'm going to present a case here. So it's a 56-year-old female with symptoms and signs of severe ulnar neuropathy, which progresses over a month. She was seen in my clinic 6 months after the onset. On examination, she presented with cubitus valgus as well as weakness in the hand intrinsic predominantly, with ADM grade 2 and then FDI grade 1, and positive Frohman sign and Wartenberg sign. So this is the incision design. And I did ulnar decompression at the elbow as well as anterior subcutaneous transposition. Then I perform beyond sonal release. Then identify the ulnar nerve and also the AIN nerve, the distal AIN nerve going to the pronator quadratus. Here you can see the AIN, the pronator quadratus has been open to expose the nerve. And then we identify the motor fascicle of the ulnar nerve. Then do a opening in the perineurium, and then transfer the AIN to the motor fascicle of the ulnar nerve. And here's the patients on month 7 follow-up.
Silakan Ibu digerakin tangannya. Oke, sekarang buka yang lebar Bu ya, tahan, buka yang lebar, tahan. Sudah bisa nahan ya. Oke, bagus.
So the hand intrinsics is improving. The ADM is now at grade 4 plus and FDI is grade 4 minus. You can still see the Wartenberg sign and the Frohman sign. But functionally, she feels that her hand function is improved significantly. So in conclusion, the RADS transfer of distal AIN to ulnar motor fascicle is a promising technique to improve motor recovery in select cases of severe ulnar neuropathy. And the outcome may be better than decompression alone. These procedures usually reserve this procedure for severe ulnar neuropathy presenting with reduced CMAP amplitude and still with the presence of fibrillations in the ulnar hand intrinsics. Thank you.
Thank you, Dr. Sanjay. So, questions for the panelists?
Hello. May I ask a question?
Yes, Jake.
Do you recommend doing the procedures at the same time? I mean, the outer decompression together with the nerve transfer, or you can wait. Maybe you do the outer decompression first and then do the nerve transfer later if the clinical is not improved. Do you have any suggestion on that?
Yeah, thank you for the questions, doctor. So I usually perform the procedure at the same time. So I do decompression with or without ulnar nerve transposition and also nerve transfer at the same time. So once I identify the patient with severe ulnar neuropathy and the NCS and EMG showed that the patient has reduced CMAP amplitude as well as fibrillations in the hand intrinsic, ulnar hand intrinsic, then I do the procedure at the same time.
Professor Spinner, any comments on this? Do you do this procedure routinely, or what is your protocol for management of severe cuboidal tunnel syndrome?
Yeah, no, I'm have not born into clinically using the reversed enticide for neuropathy. I think for traumatic lesions, it's different. My protocol has been, if I really believe a patient needs it, I do end to end. I really have not been impressed by the data. And for my patients, I've seen similar results doing a transposition in severe ulnar nerve problems. So I'm watching and learning.
Okay, so even I don't have any experience of doing this for severe. I think. Do you think, Professor Sanjay, do you think it's a good strategy to plan? Even if you plan it, then you can do it in a staged manner, like give it like 6 months, do a repeat EMG after a simple decompression or transposition, and see if there is any change clinically or electrophysiologically. If you feel that the recovery is not as per your expectation, then you probably can go ahead and do that after 6 months' time. What do you think about staging the procedure?
Yeah, I think that's an option, but by doing that, I think we're putting more time. We're delaying the procedure, and by delaying the procedure, we also delaying the motor recovery, because by waiting more in next few months, we're probably the chance of the patient recovering from the problem is, I think, is it might reduce the outcome. On the other hand, if we do it at the same time, I think the patient has nothing to lose. I mean, even doing this procedure in a patient with a normal median nerve usually doesn't affect the pronation for the patient, because by the loss of pronator quadratus is still they still have the pronator teres that will which is a stronger pronator than pronator quadratus. So I don't think it's the patient has nothing to lose in their condition. So I think doing an early a nerve transfer, I think, is more beneficial for the patients.
I think the surgeon has to lose, though, because I think we're all looking to each other to figure this out. And, Shandon, I think Raj Midha did one of the nice studies over the years. And even with that study, I think there are many questions. I think here it's how do you interpret it? So, Shandon, to get to your question, I agree. I think if you're going to do it, the benefit would be is to babysit up front. The downside, obviously, is the extra surgery and the interpretation, because, for me, my results are what they are. With someone with severe wasting at the elbow, I have trouble regenerating to the hand. That's a problem. Is this giving us more? I don't know. It's so hard to measure outcomes in intrinsic function. The downside, though, of doing it secondarily is now you've waited, so the benefit is lost about getting some axons there. But then the real problem is if there is recovery, it's probably from either the nerves growing down from the elbow taking more months, or now you're going to say maybe that recovery is because I've done this enticide. So I don't know the answer. Like I say, I'm really looking for good science and good outcomes to help me. But it doesn't really make that much sense to me. So that's why I just haven't been doing it.
Yeah, yeah.
Yeah, Professor Spinner, as you have mentioned before, so one of the possible benefit of doing this procedure is for the axons coming from the AIN to babysit the muscle while waiting for the native axons regenerating from the elbow. So in the long term, I think that's also one of the possible benefit of this procedure.
So any other questions from the panelists? Otherwise, I think we can close the session and give a break to Professor Spinner, who I think it's 3 a.m. or more in Rochester. So thank you to all the speakers for your time, for your presentation and answering all the questions patiently. Thank you to ACNS, Professor Kato, Professor Liu, Professor Rajakutty. Thank you to WFNS, the Executive Committee, Deborah, Mariano, Esham, Jitpur, for participating in this. Thank you, Dr. Spinner, for joining us late in the night. Special thanks to you for that. So over to you, Professor Liu and Raja, to conclude this session.
Okay, so first of all, I would like to thank the WFNS Peripheral Nerve Committee and the President of that committee, Prof. Deborah Garoso, and also the President of the ACNS, Prof. Yoko Kato, for having this wonderful joint venture where experts from all around the world participates in peripheral nerve surgery. As many of the honorable speakers may not be knowing that PNS surgery is not very lucrative in this part of the world, the low and middle income countries, and this is more often a fort for the plastic surgeons and orthopedic surgeons. The neurosurgeons are slowly getting into it, and I hope this webinar will have some positive effects on them, and a lot of youngsters will definitely go and to venture and become experts in field. Thank you to Chandan for organizing this wonderful foot, and thank you to Liu from the ACNS side, who has done an extensive job right from 3 years for co-hosting the webinars and educational committees. So I think I'll just let you know that this all the talks will be recorded and available on the ACNS YouTube channel. I will share the links of each talk separately and on the email. And thank you very much all for joining. Thank you. Bye-bye. See you.
We should do this again sometime soon. And
Sure.